Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Lee and Dr. Escalmato.
Well, thank you, Mandy. And my name's Walter Lee and Ray Escalmato, and we are thrilled to be with you tonight, and thank you so much for coming out. This evening, we're going to be talking in most general terms about neck masses. But you know, I was thinking that on a day like this, beautiful day after the weather that we've had, and you all deciding to spend time with us, we really got to say something more spicier than neck masses. So I've decided to rename my portion of the talk Lumps, Bumps, and Things That Are a Pain in the Neck. So now I feel like you spent your time well with us. But in the next 15 or 20 minutes or so, I'd just like to talk to you about neck masses in general, lumps, bumps, and things. But first we have to start with the anatomy. Understanding what's in the neck and what could go wrong is going to be one of the most fundamental things that we as doctors have to understand. So we'll talk about normal structures. We'll talk about lymph nodes particularly. Then clinical presentation. Talk about that and what kind of things are red flags to us for things that need to be further worked up. And if you were to visit somebody like me and you had a lump in your neck, what kind of things would you expect that would happen in terms of that further examination? And then finally, we'll talk a little bit about treatment overview. So let's start with anatomy. This is now entering the audience participation part of the talk. So I'd like all of you to go ahead and feel your neck. I'm going to walk you through this. Right in there in the middle, you're going to feel a little notch like a small V. And that's oftentimes called the Adam's apple. And that, you can see there, is right there in the middle of the screen. That's part of your thyroid cartilage. If you feel the structure just above that space, that's the hyoid bone, which you can see up at the top. Now, the interesting thing about the hyoid bone, it's the only bone in the body that is free-floating. It isn't connected to any bones, like your leg bones and elbows, things like that. It's actually free-floating. It's suspended by a bunch of ligaments. And when you swallow, if you go ahead and feel it, if you swallow, you feel everything kind of move up and down. There's a bunch of muscles that connect to that bone. And that enables that whole mechanism to work well. If you follow your finger down from the V notch, the Adam's apple, and you kind of go down, and then you feel a little space there. Now you're at a point where you're below the thyroid notch, and you're in just above the cricoid cartilage. That cricoid cartilage, which is just below your finger, is the only complete ring of your airway. And so that's a little bit of trivia you can throw out at parties, have people feel that. Now, if you think about midline, lateral structures, so if you're talking about over here, if you turn your neck all the way to the side, you feel this kind of thing pop up. That's one of the biggest muscles in your neck, which is called the sternocleidomastoid muscle. You can probably feel it down here at the bottom. If you go from here to here, you feel this thing kind of poke out. And you can see it connecting from the back of your ear all the way down. And that protects a lot of the things that are in your neck, including your carotid artery, your internal jugular vein. And you also have salivary glands that are pretty much can be found on the lateral side of the neck. Your major parotid gland kind of comes down, and a little bit of the tail can come down in the upper part of the neck. You also have two submandibular glands kind of sitting right under here. And sometimes people can confuse those for lymph nodes, and we'll talk a little bit about that. The other system of the neck or structures of the neck that we otolaryngologists are very familiar with and are concerned about is the lymph nodes. So the lymph nodes, you can see they're little green beans. They're not green literally, but they have bean-sized structures that are throughout the neck. You have 30 to 50 lymph nodes on each side of your neck. And they're connected through a bunch of vessels, lymph vessels. You can kind of think of them as blood vessels, but they connect all these lymph nodes. And they're all part of the immune system. So if you were to take one lymph node and you kind of slice it open, what you see here is a structure of the lymph nodes. You see these lymph vessels coming in. Each one has its own blood supply. And within this highly structured node is a lot of action. And what is going on is you have B cells, you have T cells, you have CD8 cells, you have dendritic cells. All the cells of the lymphatic system, your immune system, they kind of find each other in these lymph nodes. They interact with each other in these lymph nodes. And as we'll talk soon about, if cancer gets stuck in these lymph nodes start to blow up. I'm sure all of us have had colds that you're like, oh, I can feel my lymph nodes or my glands swollen. These bacteria, viruses get trapped in here, and again, the whole immune system is working in these small little lymph nodes. It's really quite amazing. A lot of my research is in immunotherapy, so I'm particularly interested in how the immune system can protect us not only from viruses, bacteria, but especially from cancers. So when you go see a doctor, we all experience the most important thing for us to understand what's going on and what the next steps for you will be. It's really the history and physical. And so all the questions that we ask you, there's very deliberate thinking behind that, understanding about what happened, when it happened, where it happened, how long it's been going on. In neck masses, some of the things that are particularly important are the age. So that's something that we can kind of assess right when we walk into the room. But for somebody who's talking about neck masses in an 80-year-old, it's very different than somebody who's an 80. Smoking and drinking, those are significant risk factors for the cancers, the most common cancers that we see in the head and neck. So that's something that we are assessing and trying to understand how that contributes to the story. And also, and simple things like infectious contacts. If you have a neck mass, your lymph nodes are popped up, and you've been around your grandkids who are, walking petri dishes, and they're sick all the time, and you've been playing with them. I mean, that's going to be kind of part of our whole process of sorting out what may or may not be going on. Then we oftentimes move to the physical examination. The reason why I started out with anatomy is because we can palpate a lot of things, and if you know what the normal anatomy is, then you can kind of understand what may or may not, may not be normal. And I can tell you that many times normal structures can be mistaken as abnormal. So that physical examination for us is very important. One of the things also is if this neck mass is tender to touch, you put that together with, oh yes, I've been around sick people, then that kind of moves us down an infectious type of etiology or cause rather than something that I think we're all concerned about, which is cancer. One of the workhorses of, so here's an example of a patient of mine. This guy is built like a linebacker football team. But you start to examine him and he's noticed some swelling on the right side, and some friends have kind of pointed out, you look a little asymmetrical, but again, you can see he's built pretty solidly. So when you examine him, you can feel that there's a mass down there, and that happened to be a benign fatty mass or lipoma. Now, look at this picture. I think all of you can appreciate that in the skin there underneath the beard, there's these kind of lumps and bumps that are involving the skin. That's actually metastatic cancer to the skin. So this patient, if you can look at the bottom of the picture, has a trach, he had a cancer. And that cancer, unfortunately, has spread to the skin. So this is just an example of just what you can gather just from the history and physical. Now, the area that we're responsible for, ear, nose, and throat, a lot of it you just can't see. I would probably guesstimate 30–40%. It's hard to see on a physical examination. You can look in the mouth, check out the tongue, look in the ears. And this is a cut of a body that you can see the nasal cavity. It's pretty large, but you see here in the front is just a little bit of what is really going on. And then if you come around here, let's see if this has a pointer. Yeah, if you come around here, all this part you just can't see in the physical examination. And so what I have pictured here is a fiber optic nasopharyngeal laryngoscopy is the procedure, but sometimes we just call it a fiber optic scope. And this scope is a workhorse for us. It's a wonderful tool because it allows us to see all these things that you can see that the normal physician or primary care physician just can't see. So this is the size of a spaghetti, and it slides through the nose. Has anyone here had this procedure done? No one's experienced the joy of having this long spaghetti with a light. Well, I'll tell you, I have. I wanted it done to myself because I wanted to know what it felt like. And I'll tell you that it's not painful. It's just kind of odd. The whole exam lasts for about 30, 45 seconds. And it's just kind of like weird. But it's not painful at all. So you don't have anything to be worried about. But with this scope, you can see the entire voice box, the whole back of the throat. It's really a wonderful tool. So after all that, depending on where the location is, midline or lateral, I just put this up as an example of the things that they could be. But obviously, we're not thinking about all these things all the time, but this is the process for which our specialty needs to kind of sort through things. So you have infections, you have congenital situations, you have cancers, you have normal things. So the thyroid lesions, these are all things that we are trained to sort out. Now, some red flags that I want to share with all of you is that when you have unilateral neck masses, and you've wanted, just for simplicity's sake, we'll compare tumors to infection. So if you have a unilateral, let's say, lymph node over here, and that's already you're kind of thinking, if you had an infection, it's kind of odd if it would just be unilateral. You think it'd just kind of be both sides. And if this mass doesn't go away, and you don't have any precipitating factors like having a cold or sinusitis, and maybe one of your doctors said, well, let's put you on some antibiotics, 10 days, 7 days, and it doesn't go away. Those are things that are red flags. Now, I have at the bottom length of time or persistent. There isn't a line in the sand that, okay, at 7 days, we're not worried about it, but at 8 days, now suddenly we're, obviously it's a gradual thing. I'll tell you that 1 to 2 weeks of a lymph node popped up, that's not something to lose sleep over. But if this has been going on for 2 to 3 months, I think you need to, and you've tried multiple antibiotics, I think at that point, you need to see somebody who's specialized in our field who can sort that out. So these are things that if we saw every lymph node that popped up, we would be in the clinic 24/7. So we work with our primary care doctors. We work with your primary care doctors to get the people that need to be seen by us, and then those that lymph node goes away with antibiotics, then great. Further workup can include things like CAT scans, ultrasounds. I have an example here of a CAT scan. Just out of curiosity, has anyone undergone a CAT scan? Okay, so it's basically a specialized X-ray. And how we look at these is simply, you have to imagine if you're looking at somebody on the table from the feet up. So that means over here is left side, over here is right side. And you can also think of that, there's 3 major colors in a CAT scan. There's white, which is bone. You can see here the spine. Okay. And then there's black, which is air. Over here is air, and then here's the airway. You can see black. And then gray is pretty much tissue. But this probably caught your eye pretty quick. There's this big neck mass here on the left side. Now, oftentimes, even though you can palpate these neck masses, we get these scans for other reasons. I think for this situation, here's your vessels, your carotid and your internal jugular vein. I was wanting to see what the involvement was of this neck mass. So there's a lot of details that we look at. And here's actually the tumor that this tumor spread to the lymph node. So this is an example of some of the things that we see often in the course of our practice. The other thing that I want to mention is there's this procedure called the fine needle aspirate or fine needle biopsy. This can be done for neck masses. It can be done for breast masses. It's done for a lot of things. I want to take a historical digression, though, and introduce you to a guy named Hayes Martin. He lived there in 1892 to 1977. Hayes Martin was a general surgeon, but he focused on head and neck cancer, so kind of see him as one of us. He's actually considered one of the fathers of our field. He practiced up in what is now Memorial Sloan Kettering in New York. And he kind of brought the whole concept of fine needle aspiration to America. So actually there are reports of people trying to get a little bit of sample of these kind of lesions in Arab countries way back, but this guy really took it to modern day medicine. And this is the story that's told. So he was a resident making rounds on some patients up there in New York. And this patient, this particular patient had kidney cancer. And they also found out that, oh my gosh, he has a lung mass also. And I guess during the rounding, the doctor in charge said, you know, that kidney cancer spread to his lungs, which happens often. But Hayes-Martin was not convinced. It just didn't look quite right, what he normally saw about metastases to the lung. And he just was like, no, I don't think that that's metastasis. I think that's maybe a lung cancer. Well, you know, being a resident, he wasn't listened to. He's like, what do you know? But I guess the patient ended up dying in the hospital. I don't know if it was a week later, let's say. And in the middle of the night, Hayes-Martin went down to the morgue, took a recent chest x-ray of this patient, and saw where that lung mass was, took a needle and tried to hit it, got some cells. He went to the pathologist and said, could you take a look at this sample I got? And lo and behold, it was lung cancer. It wasn't kidney cancer. So he was right. Well, his superiors found out what he did. He got into big trouble. I'm sure he's probably threatened that if he ever pulled a stunt like that again, you know, he can find himself a new job. But you know, he never forgot that was a great non-invasive, pretty much non-invasive technique. So then when he became the surgeon at Memorial Sloan Kettering, he partnered up with another pathologist, and they started working on this technique, and that's pretty much what we use now. So now you have a little bit of historical trivia to share with your friends. Hayes-Martin. So let's talk a little bit about treatment overview. You know, our field, otolaryngology, head and neck surgery, sometimes referred to as ear, nose, and throat, it is a really unique specialty for a variety of reasons. One, we in our specialty have a lot of medicine as part of what we do, and we also, of course, learn surgery. And so when you see somebody like us, we know the medical treatments oftentimes, and we're very happy to do that. I mean, even though we're surgical subspecialty, if medicine can take care of it, great. But if you needed surgery to take care of it, we're also the same people who can do it. And we're really regional experts in this area. So if you think about heart surgeons, you think about, you know, kidney doctors, or a lot of medical specialties are organ specific. But for us, we're regional specific. So we are experts in the airway. We're experts in everything that lives in the neck, the thyroid, the lymph nodes, nerves. It's really a unique way of understanding and treating patients, which I particularly appreciate. The other thing is, when we talk about cancer, if you imagine a cancer popping up on your tongue or in your throat, it really takes a multidisciplinary team to cure. And what I mean by that is, of course, you have the otolaryngology doctors, but you also have medical oncologists who give chemotherapy. You have the radiation oncologists. We work closely with endocrinology for thyroid cancers, which Dr. Escamato will talk a little bit about. And then oral surgery. We all work together as a team. It's really, it really does take a team to cure. And even if somebody just needs surgery, we get the other opinions and expertise of the other teams to weigh in and be like, yes, we agree with you. It's multidisciplinary care. I really consider it the standard of care. Here at Raleigh, we have that. And at Duke, we have that. So it's really a wonderful team. I don't want to stop there, though, because in our field, it's not just about curing, it's about maximizing quality of life. And so not only do we have all those people that I spoke about, but we also have other folks that, you know, help us maximize that quality of life. Speech pathology, dietitian, nutritionist, social work. I mean, it really is a multidisciplinary team that you get, at least when you come here at Duke. And it's an honor to be part of this team. And I hope that you never get this situation that you have to come to see me for cancer. But if you did, I think it's really, you're in good hands. At this point, I'd like to turn it over to my chief, Dr. Escamato.
Thank you, Walter, and thank you everyone for coming tonight. I tend to talk softly, so if you can't hear me, just please raise your hand and I will try to speak up. Walter assigned a very narrow focus for me because he's a lot smarter than I am, and this way I can kind of stay on base and not get off track. So he talked about the whole head and neck. I'm going to talk about one thing, which is the thyroid gland, okay? This is the thyroid, this is the larynx that Dr. Lee was talking about. The thyroid lives just below that, just right in the middle of your neck there. And it's an important organ because it makes a hormone called thyroid hormone that every cell in your body needs to live. And if you don't have it, everything will eventually shut down. And it's also important because this is probably the next epidemic that we have. And in my mind, I'm not sure it's an epidemic. And I hope that is kind of the lesson or the take-home message that you'll get when I finish this next 15 minutes or so. So, thyroid nodules are actually very, very common. How common are they? If you examine every single patient, about 1 in 20 will have a nodule that you can feel. And usually they have to be about 1/2 inch in size to be readily felt. In autopsy studies where people have actually looked at the thyroid gland, about half of what are thought to be normal glands will actually have nodules in them. And that's just a growth. But only about 4% of them are actually cancer. So nodules are very common. Cancerous nodules are very uncommon.